All right. Well, thank you all for sticking out. It's been a great day of great talks, and there's still a few more to come. I'm going to speak a little bit about the management of upper tract urothelial cell carcinoma as we start to finish up the day, and some things that I've experienced, and show you some of the cases that I've done, because I think experiential learning here is probably very effective. So when we talk about upper tract urothelial cell carcinoma, I think the most important thing to understand is that upper tract urothelial cell carcinoma is different than bladder cancer. Too many times we assume that upper tract, because it's urothelium, is the same as bladder cancer and bladder urothelium, when actually they're derived from different embryologic origins. There's different kinds of tissues, and so upper tract urothelial cell carcinoma is a different disease, and so we have to think about it. And when you consider a conservative approach, while we start to get into new paradigm shifts, things to remember is that with upper tract disease, there's a high risk of recurrence. You have to keep that in mind. And high-grade tumors may not be the best situation for kidney-sparing procedures. And clearly, the gold standard of doing a nephroureterectomy is nice, because once you do that, you don't have to worry about recurrence. But it all depends on the patient. And in fact, a systematic review by the EAU of over 22 trials showed that those patients with low-grade upper urothelial cell carcinoma had the exact same survival as those that underwent a radical nephrectomy. So when we start this approach and we start to think about these patients and who we should do, obviously those patients with a solitary kidney, they're ideal candidates for that. Those patients that may have bilateral upper tract disease or Balkan nephropathy, nephron-sparing surgeries may become essential. Sometimes genetic associated disease like Lynch syndrome, which typically is low-grade upper tract, these are all ones that we should consider for nephron-sparing surgery. We also have to think about CIS in the upper tract is different than low grade, right? CIS is high grade, it's high grade dysplastic. Those are different patients than what we're talking about here. And again, whenever we talk about nephron-sparing surgeries for these upper tract urothelial cell carcinomas, we have to be thinking surveillance. So the other fortunate thing is these are rare tumors. Upper tract urothelial cell carcinoma in the face of all urologic malignancies typically are rare. For those patients with bladder cancer, they will if you follow their natural history, 2 to 4% of them develop upper tract disease. Whereas if they have CIS in their bladder, the chance of them getting upper tract disease is much higher. And again, most people that have upper tract disease present in their 8th decade. I think really where the controversy starts to exist in upper tract disease is, how do we differentiate those that we can help and have nephron-sparing surgery versus those that need nephroureterectomy? And that's where biopsy and the tissue tells us. Because at the end of the day, it all is about pathology and histology. So in 1973, the brush biopsy was introduced. The problem with the brush biopsy, as you know, it's a cytological analysis, and it does have a high degree of false negatives, so you may not get all the tissue you need. The Segura basket, my mentor was Dr. Joe Segura. I worked with him when I was a resident. He came up with a stainless steel basket that was great for snaring tumors and actually avulsing them. Then you've got the ureteroscopic piranha biopsy that you can get in there. And probably one of the things that I like best is this bigopsy. Now, one of the things about the bigopsy in endourology is this is a perfect situation where you need to have that ureteral access sheath, because the bigopsy is backloaded on your flexible scope. And it is so big that it obscures the view. You essentially want to drive it into the tumor and grab that tumor. The advantage to the pathologist is they get 10 times the amount of tissue to make an accurate diagnosis and for staging, because at the end of the day, tumor histology is the most important prognostic significant indicator, whether it's high-grade disease or low-grade disease. So let's talk about one of my patients. So this was an 82-year-old man, had a history of prostate cancer, underwent radiation therapy a long time ago. He had biochemical recurrence. He's been going around on hormone ablative therapy intermittently. He has a history of smoking. He's got a surgically complex abdomen where he's had hernia repairs. He's had an umbilical hernia repair with mesh. He's had a AAA repair. He had a MAG3 scan showing pretty good renal function. and a creatinine of 0.8. So what did his test show us? Here you can see cross-sectional CT. It's a little bit hard to see, but you're starting to maybe see something up there. You're starting to see a little bit something more up there. Then you're starting to see something here on the other side, and you can see that's pretty high volume. That's not just a small pedunculated little lesion. When you look at it with contrast, you see that filling defect. Let me go back one. You see the filling defect on one side right here. You start to see the filling defect on the other side. And in fact, in this right ureter, as I show, he's got some more filling defect actually in the ureter as well. So he's got urethral pathology as well as bilateral upper tract urothelial cell carcinoma. So what's the option in this 82-year-old man? Is it to make him completely anephric and take out all of his kidneys and put him on dialysis? I would argue that that's essentially a death sentence. So when we think about upper tract urothelial cell carcinoma, we have to think about the treatment algorithm. And when we think about the algorithm is we really have to define those patients that are high risk from low risk. And we have to think about what our goal is. We know those that are ideally situated for upper tract conservative therapy maybe have low grade, that grade 1, maybe grade 2, single papillary lesions, negative cytology, a unifocal lesion, or a low volume of disease. There it's very easy to see conservative therapy. But sometimes we have those patients that are poor surgical risk. Maybe they're not going to do well on diagnosis. So that's allowing us to push the normal boundaries of where we go. And why do I say that we push these boundaries? This is where we take a page out of what we know from the radical nephrectomy literature. We know that for a patient with renal cell carcinoma, when you do a radical nephrectomy versus a nephron-sparing surgery, the progression to new onset 3B chronic kidney disease is 43% versus 7. So there's a reason to try and preserve that renal parenchyma. We saw earlier in an earlier talk that they have improved cardiovascular and overall survival. So now we're changing the impact of the disease. We're preserving the patient. And for those patients that do have end-stage renal disease, depending on your decade of life, your 5-year overall mortality is 10%. So in this 82-year-old man, if I put him on dialysis and make him dialysis dependent, his chance of him being alive in 5 years is only 10%. So I would say I have a reason to fight for and try and preserve his renal parenchyma. So what do I mean by conservative therapy? Obviously, there's ureteroscopy treatments. This is a great time where you use ureteral access sheaths. You can use the bigopsy for your diagnosis. You can use lasers to ablate that tissue. We now have small fiber lasers. You can even use a Bug-B electrode that reaches up there and can ablate some of that tissue. You have to be careful in the ureter because it is thin-walled, and the last thing you want to do is violate the urinary space. You don't want to take an organ-confined disease and give it access to the retroperitoneum, where now you've taken organ-confined urothelial cell carcinoma and you've given it access to the retroperitoneum. So it's important to think about that. And in fact, Storz and Olympus make a ureteroscopic semi-rigid resectoscope, and I've used this on several occasions, which is great if your pathology is confined to the lower part of the ureter. If it's higher part of the ureter, it's a little bit more challenging. So what's the theory behind doing organ-sparing treatment? If you look back here, this was a very large series of about 417 patients. Most of them underwent ureteroscopy for the management of their upper tract urothelial cell carcinoma. 15 of these patients had percutaneous involvement, and you can see from the Kaplan-Meier curve here that overall survival, when you're able to preserve their kidneys, is much improved. You can see they followed them for a long time, but when you read the paper and you look at it, the overall recurrence rate is almost 70%. So I can't reiterate enough how important it is to have close surveillance of these patients. 40% of them had bladder cancer develop. 20% of them eventually progressed to nephroureterectomy. But if you looked at their data, over 88% had a disease-specific survival. They were able to preserve the renal function for some amount of time in almost 85% of these patients, and their overall survival was almost 70%. That's really good for upper urothelial cell carcinoma. The most common complication in this particular series was the development of strictures, which happened in about 16% of the patients. And when you looked at these patients, when they had their percutaneous procedures, there was no tract seeding seen in any of them. So we always worry about, well, if I violate this, am I going to get tract seeding? So it's something to consider. Let's go back to my patient. What I ended up doing with that patient is I did right ureteroscopy. I laser resected that urethral tumor. I also went in and did simultaneous left ureteroscopy and ablated as many of the tumors as I could, but based on that pedunculated lesion, I did a left percutaneous resection. Once I had the pathology back and it confirmed for me that it was low grade, because when I initially saw the patient, he had that high grade disease on his right. I said, well, I may have to do a right-sided nephroureterectomy and let's see if I can at least preserve renal function on the left. Everything ended up being low grade disease. So I took him back to the OR several more times for repeated procedures over 18 months. Everything came back as low grade. I did treat him with some antigrade mitomycin, and I'll share with you a little bit my thoughts on how that works in just a minute. But again, the most important thing, again, I reiterate, is that a lot of these recurrences may not be available or be able to be seen radiographically. So when you have these patients and you're going to treat them, it almost mandates that you do periodic ureteroscopy to inspect their urothelium directly. Here he is in the post-op. Here you can see the kidneys, the lack of filling defects, no more ureteral pathology. And he's now 86 years old and he's disease-free and his renal function has been maintained. Now, just because we did that in one patient doesn't mean that's all patients. Here's another patient of mine, an 89-year-old gentleman. He was actually very younger than he looked at 89. He had a history of bladder cancer. He has a history of upper urothelial cell carcinoma, and he underwent a left radical nephrectomy in the past. But all that pathology came back as non-invasive, low grade. So what happened is he had a recurrence in his ureter. They did a distal ureterectomy. His son and daughter were physicians, and they said, we don't want him to make him anephric. We know what the data is in this 89-year-old, that if he's on dialysis, he's not going to be with us. So I'll show you his x-rays. This is an MRI on this patient. You can start to see right here in this collecting system, this big mass. This is not a small pedunculated little tumor. So I said, whoa, I'm not sure we're going to be able to save this kidney. That is a big mass in there. So what I ended up doing was doing a combined approach in this patient. I went in from a retrograde to look at the tumor, and then I ended up doing a perc and resecting that, and I left him with a antigrade perc tube, and I'll show you what his results were in just a minute. I would say that conventional percutaneous treatment is a very viable based treatment for these large tumors, especially if they're low grade. You can go in and you can resect them almost like you would in a TUR. This is an old series from Arthur Smith where he did this, and they looked at how many kidneys they were able to preserve. Showed that after they did their initial percutaneous debulking, if it was low grade disease, the risk of nephrectomy was almost 0%. The higher the grade of disease, again, that cellular atypia, the higher the risk of recurrence and the higher the risk of nephrectomy. But again, in their series, in all those kidneys, they had 0 tumor recurrence. Here's that same patient 3 months later. You can see that I left that neph tube because I was giving antigrade treatment. I did have an upper pole access, but he had this recurrence here. You can see it under endoscopic vision there. I was able to burn it and free it up, and he still is disease-free. So I haven't put this 89-year-old gentleman through any massive life-changing and life-altering surgeries. A couple words about instilling different therapies in. I don't like to put BCG in the upper tract, especially for low grade. It's not very effective, but I think mitomycin does have a role. What I'm showing you here is when I do mitomycin, I don't connect it to a bag. I actually put it on a syringe pump because the most important thing in terms of tumor ablation is the dwell time. So it's important for 1 cc per minute. So they're getting their therapy over an hour and a half to 2 hours because it increases the dwell time in that renal pelvis and around the collecting system. I think putting stents up from below and filling it up with the bladder and hoping you get retrograde, I think that doesn't work very well at all. My third and last patient I'll share with you was a 78-year-old lady. She had a history of bladder cancer. She had undergone a partial nephrectomy for renal cell carcinoma. She had a tumor ablation on that same side. She has chronic renal insufficiency as well as diabetes. She presented with a new filling defect that you can see right here. You can see here's the filling defect. Here's what you can see ureteroscopically, and you see the tumor burden here. And so I was thinking, boy, this is such broad disease. How am I going to resect this and her not have a terrible scar up there? So this is where we actually participated in the Olympus trial. This is essentially a thermosensitive polymer gel that you inject into the kidney. When it's cold, it's in its liquid form. When you heat it up to body temperature, it kind of turns into a gelatin type substance, and it slowly releases the material, the mitomycin, over 3 to 4 hours. This was the phase 3 trial, and they've kind of unblinded the first results at this year's AUA. I think they're giving us an update, but I have several patients in this trial. What this gel is basically, it's cold, you put a catheter in, you inject it in, and you're chemically ablating the tumors. So part of being in this trial was I had to leave tumors in there untreated, which as a urologist or a surgeon, it's very hard to leave tumors untreated. But in most cases, and in the animal studies and the human studies, this material is almost completely gone within 8 hours. It shrinks, so urine drains around it. But as we know from bladder cancer and mitomycin, you can't have acidic urine. So we always treat these patients, pre-treat them with sodium bicarbonate so the material stays into the kidney.
4 minutes left.
Okay, so the side effects from this are with mitomycin, nothing much there that people aren't already aware of mitomycin. The interim analysis that they did with this first therapy was 34 patients. The endpoint, they had a 60% complete response. That's really good. Again, this is low-grade upper tract urothelial cell carcinoma. They had partial responses. My patient is out a year. Let me show you what my patient looks like. At 6 weeks, those pictures that you saw before, you can see the treatment effect where it's just fibrinous material. And then when I looked back there in 6 months, all that tumor has been completely ablated and is gone. She's been a complete response. And for somebody who you're trying to preserve renal function, this can be a really nice adjuvant. I will say that this does come with a word of caution because mitomycin, just like in the bladder, if you get a bladder perforation or rupture, you get scarring and strictures around the bladder. The biggest downside is you can sometimes get strictures around the ureter too, and my patient did have a stricture there that I then had to deal with. So my time's running out, but in summary, I would like to say that when it comes to upper tract urothelial carcinoma, we're having a paradigm shift. We have advanced technologies and advanced tools. The most important thing is you have to risk stratify your patients. This isn't appropriate for everybody, but it certainly should be used for a lot of people. I think we can spare some kidneys. And again, if I can't reiterate it enough, the most important thing is surveillance. And surveillance doesn't just mean cytology and x-rays, but it means actually visually inspecting the urothelium with an endoscope. And I think that topical therapy like BCG hasn't shown an effect yet, but I think this mitogel may offer us some new promises. I asked the company, why do they start with mitomycin? To me, as a urologist, it makes more sense to start with gemcitabine, Valstar, Gemzar, but this is where it started with, and we'll see where it goes. And especially for those patients with genetic predisposition for upper tract, this is something to think about, those with Lynch syndrome. So again, as I finish up, again, I want to thank the organizers, the moderators, and everybody for inviting me. It's been an incredible weekend, an incredible meeting, and I can't thank you enough for your hospitality, and I've really enjoyed myself, so thank you.